Hello and welcome to The Deep Dive. Today we're tackling a topic many have heard of, but maybe don't fully grasp: lymphoma.
That's right.
We're going to unpack this complex group of cancers, look at how they differ, and explore some of the really incredible advancements in treatments.
It's a fascinating area.
Our mission today, to give you a much clearer picture of what lymphoma is and, well, why diagnosing and managing it is so unique. Okay, so let's dive right in. What exactly is lymphoma, and where does it actually start in the body?
Right. So lymphomas are essentially cancers, neoplasms that arise from lymphoid tissues, part of your immune system, basically.
The immune system, okay.
And are primarily diagnosed based on what pathologists find in a biopsy sample. What's interesting is that the vast majority, most of them start from B cells, a specific type of white blood cell.
B cells. Got it. Now, we often hear these terms thrown around, Hodgkin and non-Hodgkin lymphoma. What's the fundamental difference there?
Yes. What's really key for Hodgkin lymphoma, or HL, is the presence of something called Reed-Sternberg cells.
Reed-Sternberg cells.
Yeah, they're these large malignant B cells, and typically they're surrounded by many other reactive non-malignant cells. It gives it a very specific look under the microscope.
Sort of a defining feature then.
Exactly. Non-Hodgkin lymphoma, NHL, well, that's a much broader umbrella term. It represents these monoclonal proliferations, uncontrolled growths of either B cells, which is about 90% of NHL cases, or sometimes T cells.
So NHL is more of a catch-all for other types.
In a way, yes. And thinking about non-Hodgkin lymphomas, another really important distinction is their grade.
Grade, meaning how aggressive it is.
Precisely. High-grade tumors, they divide really rapidly. They can become life-threatening quite quickly, sometimes developing over just weeks. Low-grade tumors, on the other hand, divide much more slowly. They might have been present for months, even years, and generally behave in a more indolent fashion.
Indolent. That word really stands out when you think about cancer.
Yeah.
Slow growing. So for those low-grade NHLs, can people actually have it for a while and not even know, be asymptomatic?
Absolutely, yes. Low-grade NHL can be asymptomatic for many months, sometimes years.
Wow.
Which, raises a really important point about how they're managed. Does it change the approach?
Yeah, how do you manage something like that if it's not causing problems right away?
It's a great question. Often, for those truly indolent cases, doctors might actually adopt a watch-and-wait strategy initially.
Watch and wait. With cancer.
It sounds counterintuitive, I know, but it involves careful monitoring because jumping into aggressive treatment might not be necessary right away, and, well, treatments always carry their own risks and side effects.
That makes sense. Okay, moving from types and grades, what does lymphoma actually feel like or look like for a patient? What are the common signs someone should maybe look out for?
Good question. The most common thing we see for both types, actually, is painless, kind of rubbery lymphadenopathy.
Fancy word for swollen lymph nodes.
Exactly. Swollen glands, often in the neck or maybe the collarbone area, and they don't hurt, which is key.
Painless, okay.
Both types can also present with what we call systemic B symptoms. These are important signals.
D symptoms, what are those?
Things like drenching night sweats, fevers without an obvious infection, and significant unexplained weight loss, usually defined as more than 10% of body weight.
Okay, those sound more serious.
They often indicate a more active disease, yeah. And there's a difference in spread, too. NHL often presents more widely spread out, sometimes in extranodal sites, places outside the lymph nodes, like bone marrow or the gut. Hodgkin lymphoma, HL, tends to spread more predictably, sort of step-by-step, contiguously, from one lymph node area to the next.
Interesting difference in how they travel. So if someone has these signs, what's the diagnostic journey like? I'm guessing it involves more than just feeling for swollen glands.
Oh, definitely. The cornerstone, the absolute key for diagnosis, is a lymph node biopsy. Getting that tissue sample looked at under the microscope is the histological hallmark.
The biopsy confirms it.
It confirms the diagnosis and the type. But then, determining the extent of the disease, how far it spread, is equally crucial for planning treatment. That's where staging comes in.
Staging, right. How's that done?
We use imaging tools like CT scans, and especially PTCT scans. P-scans are incredibly useful because they light up areas of active disease. They allow for really accurate staging and also help us monitor how well the treatment is working later on.
So P-scans give you that functional picture, not just the anatomy.
Exactly. You see the metabolic activity of the cancer.
Okay, so diagnosis, staging, which brings us to treatment. It feels like there have been huge breakthroughs here. Is that fair to say?
Absolutely. It's a rapidly evolving field. The main goal is always twofold. Maximize the chances of cure while minimizing the long-term side effects, the toxicity.
Makes sense.
Standard chemotherapy regimens like ABVD for Hodgkin lymphoma or RTHOP for high-grade non-Hodgkin are still very important foundations. There's our combinations of drugs.
ABVD, RCHOP, common acronyms in oncology.
Yes. But what's really changed the game are the targeted therapies. Rituximab is a prime example. It's an anti-CD20 monoclonal antibody.
So it targets a specific protein.
Right, CD20, which is found on most B cells. Adding rituximab to chemotherapy making RCHOP, for instance, has revolutionized the treatment of B-cell lymphomas. Outcomes improve significantly.
That's amazing.
What else is new? Well, for Hodgkin lymphoma that comes back, relapsed HL, we now have things like antibody drug conjugates. Think of them like smart bombs, like brentuximab vedotin, and even immune checkpoint inhibitors, drugs like pembrolizumab and nivolumab, which basically take the brakes off the patient's own immune system so it can attack the cancer.
Unleashing the immune system itself.
Precisely. And for high-grade NHL, particularly for patients who have relapsed multiple times, CAR T-cell therapy is a major, major advance.
CAR T, that's where they engineer the patient's own T cells, right?
Exactly. Take out T cells, genetically modify them in the lab to recognize and kill the lymphoma cells, grow them up, and infuse them back into the patient. It can lead to remarkable responses in very difficult situations.
It sounds like the prognosis, the outlook, must have improved dramatically then.
It really has. For early-stage Hodgkin lymphoma, over 90% of patients achieve complete remission, and most of those are cured. Even for advanced HL, long-term survival is now pushing beyond 80%.
That's incredible progress.
And for high-grade NHL treated with RCHA, about half of patients achieve disease-free survival at 5 years. So yes, the landscape is constantly improving, but
there's always a but in medicine, isn't there?
Well, yes. With these powerful treatments and longer survival, we are now facing the challenge of managing long-term side effects. Things like secondary cancers years later, or heart issues from certain chemotherapies, or the unique toxicities associated with CAR T. It's a constant balancing act.
Balancing cure with quality of life down the road. Well, from those tiny Reed-Sternberg cells under the microscope to the really sophisticated power of CAR T therapy, this deep dive has certainly shown how far we've come in understanding and treating lymphoma. It really is a testament to scientific progress. And as we wrap up, it feels like the key takeaway is that even with all these breakthroughs, the future really lies in that personalized approach, understanding the unique biology of each lymphoma in each patient.
Couldn't agree more.
And always wrestling with that challenge, maximizing the cure while minimizing the long-term costs for patients who, hopefully, have many decades of life ahead. Thank you for joining us for this deep dive.